Hello, and welcome to the Alabama Public Health Training Network. I'm Bill Kennedy, State Social Work Director for the Alabama Department of Public Health. Thank you for joining us today for our program, Ethical Practice in Helping Professions. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on our screen now and will appear again later in the program. Also, the handouts, sign-in sheets, and evaluations are all available online. You'll need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CEU credit will only be awarded for 1 year for nurses, expiring on March 31st, 2020, and 2 years for social workers, expiring on March 31st, 2021. If you're watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching on demand, it is considered non-classroom hours. Today, we will look at 7 situations where unethical, unprofessional, or illegal behavior is exhibited. Then we will discuss the behavior exhibited in the situation and review the National Association of Social Work Code of Ethics, as well as the Alabama State Board of Social Work Examiners Administrative Code. We'll also discuss information related to requirements in Alabama for continuing education. Now, let's get started. Excited that you're here this morning. We're excited about this training. This training is a little bit different. This program's a little bit different from some of the programs we've done in the past. To give you a little bit of background information on how we came up with this idea and what the plan for today is. A few years ago, Samaria Dunson was our compliance, our HIPAA compliance person, and she would do a monthly 5-minute HIPAA training. We would have a skit, and we would do something crazy, maybe a little illegal, maybe incorrect, and then Samaria would come in and say, no, please don't do that, and talk about why that was incorrect. And so with that said, we've had a lot of feedback over the last couple of years. Samaria left us and moved on to bigger and better things. But we've continued to get people that say how much they enjoyed those trainings. I think some of the skits are still out there, maybe in orientation. I know they're still out there on YouTube. And so occasionally I'll have somebody say, I recognize you, I remember you from the skits, and we really like those. And so back before Christmas, we were talking. Meg May called me up and said, Bill, you know, we need to do some skits. We need to do some ethics training. And so from that, we started talking about maybe we could possibly do that. We started looking at different ethical issues that affect us here in Alabama. And from there, we started talking about possibly putting together this training. So with that said, we started writing some skits, started coming up with some research, talked to the Alabama Board of Social Work Examiners and other people involved in ethical situations and discipline. And so we started looking at what's the biggest issues in Alabama, and we started writing those skits and started putting together this training. We tried to make it humorous. Hopefully you'll find that the skits are entertaining, have some entertaining components to it. Certainly ethical issues are not, are serious, and so I want to say that up front. We understand that there are going to be some situations that are not necessarily humorous in the literal sense, but hopefully the skits are going to be at least entertaining from that standpoint. I also want to add that the skits are not actual cases, not situations that have actually happened. There are situations that might sort of have happened, but we just wrote the skits based off of what we were reading, what our research said, and those kinds of things. So we didn't take a specific case and document it. I'd like to introduce our actors. Like I said, Meg May is our Southeastern District Social Work Director. She's the one that kind of got the idea going that we should do this. She's also one of the actors. She's in 3 or 4 of the skits, helped write the skits, and provided a lot of feedback. Kimberly Edwards, when I asked for volunteers, Kimberly was the first one that said, I want to be a part of it. She's our East Central District Social Worker Director here in Montgomery County. And this was her first time doing skits, so we were really excited to have Kimberly join us. Carol Heyer has been around, and she's a retired public health social work director back with the waiver and ED waiver, as well as with several other things recently. Carol's also got a lot of experience with acting and directing, does some local theater, and provided us not only with an actor, but as well as helped with directing and helping rewrite some of the skits and writing some of the skits. Brent Hatcher and I have done several skits back with Samaria, and Brent's been begging to get into a skit again, so he was one of the first ones I called. He's our Director of Human Resources here with Public Health, and you'll see him in a little bit. In addition, Carl Bryant just happened to be walking by the studio, and we needed an extra person, and so he volunteered. He's with the Office of Management Support. April Golston is upstairs in our office as the telehealth program manager, and April and I are working on a potential ethics training for later in the year related to telehealth and telemedicine, and so she graciously volunteered and did a great job, and we'll appreciate her helping us out. And then our last actor is Winton Kennedy. He's my son, and he also got kind of voluntold, and thank him for helping us out. So, with all that, let's talk about our objectives. Today we're going to talk about why ethics training is important. We're also going to understand the continuing education requirements for ethics training. We're going to be familiar with the NASW, the National Association of Social Work Code of Ethics, and then also be able to list several unprofessional behaviors that can lead to discipline within the helping profession. So, with that said, I want to talk a little bit about how I came up with the skits and how we came up with the different ethical situations that we are going to highlight today, and that most of those had to do with a conversation I had with the Board of Social Work Examiners. Looked at their website, did some research there, talked to them about what are some of the biggest discipline issues that they have with social workers, and then we also looked at what is also some things that nurses are being disciplined for as well. And so that was kind of the basis of the training, of where we started from, and what we hope to accomplish today is to just highlight some of the unprofessional behaviors that can lead to discipline within the profession. So the biggest question I kept getting asked was, why are we doing an ethics training? You know, why put all this work into ethics and into the training? And, you know, you don't have to go past this morning's newspaper or the early morning news shows to see that ethics issues happen all over the country. They're in businesses. We saw where there was a fine laid down yesterday for a company doing unethical business practices. University was fined this past week for some grants, some data that they used that was incorrect, and these fines are not small fines. They're in the millions and hundreds of millions of dollars. And again, banks and politicians. Recently, the college entrance exam entrance issue that's going on right now. So ethical issues are common all over our country in a variety of different businesses, organizations, and the healthcare profession is no different. I pulled from the NASW Code of Ethics some basic stuff. Social workers' primary responsibility is to promote the well-being of the client. And also from the Code of Ethics for nurses, the nurses promotes, advocates, and protects the rights, health, and the safety of the patient. And so ethics is the biggest part of what we do in the healthcare profession, and so it plays a big part in what how we treat our patients. As I noted, the code of ethics, there are a lot of different codes of ethics. I posted some pictures here. The NASW Code of Ethics for social workers, Code of Ethics for nurses, as well as the Code of Medical Ethics through the American Medical Association. And some of the reasons that there is a Code of Ethics for healthcare professions has to do with how close we work with our patients. Our patients rely on us in some of the most difficult times in their lives when they're going through health issues, whether they're going through maybe some counseling, whether they're going through psychiatric issues, whether they're going through mental health crisis, financial crisis, educational crisis, and they're looking to health care professionals for that support and for that guidance. That trust that our patient has with the worker, whether it's a nurse or a social worker or a doctor or other healthcare professionals, it has got to be to the utmost. And so the Code of Ethics is there to protect the patient. It's also there to define our practice, who we are, what our goals are as social workers, nurses, doctors. In addition, it kind of guides our care. And so we can look to the Code of Ethics as this is how we are to practice. Certainly want to point you to the Code of Ethics for your profession and encourage you to continue to review it and to follow up on it. And we'll talk a little bit more about that as we get through the training. So, as I was doing some research, I came across the 4 principles of healthcare ethics, and I want to talk about each of those briefly, and then I want to just have them there for you to reference as we go through the different skits on how these principles of healthcare ethics are going to dictate how we react to each situation. The first one talks about autonomy, the right of the patient to retain control over his or her body, basically to be able to make their own decisions. And it's not the practitioner's place to put their own opinions on how a patient makes those decisions. It's the patient's choice, and so we're there to provide information, education, but it's the patient's decision and their body and their mind and their life. Beneficence is the second one. The provider must do all they can to benefit the patient, do the most good for the patient. And from this, it continues on a little bit to say that we must maintain our skill level, that we need to have training, that we must stay current with the best medical practices, and also part of this is also considering the patient's current condition. And so that's the second one. Non-maleficence, to do no harm. That's one that we probably are most familiar with. It's kind of the bottom line is make sure you do no harm. If you're not doing any good, at least don't do any harm. And this goes not only for the individual, but for maybe the family unit or the society or the community, whoever it is that you're working with, do no harm. And finally, justice. Fairness, equal distribution of resources, and upholding applicable laws. In addition, I would say that even advocating for new laws, if applicable laws are not sufficient, and seeking equality for each individual within the community to make sure that justice is being prevailed. This information comes from Tom Beauchamp and James Childress in their Principles of Biomedical Ethics from back in 1985. So, this brings us to our first skit. This one is on fraud and deception, and again, the situation may be a little familiar, but it's not specific to any individual that has, we didn't write it off of any specific person. And so let's go ahead and take a look at it. If we can go ahead and roll the clip.
Hey,
Hey.
are you going to do that home visit with Miss Smith today?
Well, I need to. It's really hard to talk to her on the phone. You know, she's so hard of hearing.
Well, what time do you think you'll go today?
I don't know. The earlier the better, probably. Remember, she lives at the end of that long dirt road. It's really hard to get down there to her.
Well, I hate to tell you this, but it's supposed to rain later today.
Oh, great. I'll probably get my car stuck in the mud again. You know that's already happened twice.
Oh, my goodness.
Yeah, and on top of that, her nurse is supposed to visit today. I just hate to make my visit at the same time the nurse is there.
I hear you. Well, you know, good luck with that. I know you'll figure something out.
Yeah.
Talk to you later.
I'll figure something out. I do not want to make that visit today. I know my car will get stuck in the mud again, and I'll probably show up at the exact same time that the nurse is there. And it's so hard to get my visit done anyway. She's so hard of hearing, and she has dementia. She has dementia. She won't remember if I was there or not. I think I did just figure out something. Okay, today's date, home visit made today. Problem solved and nobody gets hurt.
All right, so our workers there are trying to come up with the best way to go see a patient, and ultimately they come to the conclusion that not seeing the patient is the best way to see the patient. Unfortunately, that has actually happened, and I know of some situations in the past where that happened. And unfortunately, those people got in some trouble. And there's a couple of different things that go along with that. Certainly, it's not only fraudulent. She's apparently documenting that she did this, but she's also going to bill for that visit. And so we've got some illegal issues that are going on as well. Let's talk about it a little bit, though. And so I got here from the Code of Ethics, Social Work Code of Ethics, Sections 3.04. You know, the social worker should take reasonable steps to ensure that the documentation in the electronic and paper record is accurate and reflects the services provided. And also, social workers should not participate or condone or be associated with the dishonesty, fraud, or deception. And that's from 4.04, dishonesty, fraud, and deception. In addition, we talked a little bit about criminal activity. And so here the worker has made a statement in the record that she actually did something that she really didn't do. And it could be illegal. It is illegal and could vary from state to state. The consequences for that, consequences could include both fines and or jail time, depending on your state and the severity of the action. Ethically speaking, you know, she's taking advantage of the patient. The patient was due a visit. Who knows what's going on in that patient's home today that she's not going to discover. The records are not going to reflect the patient's true history. So it's going to show that a visit was made, and since she's just kind of making up what happened, we don't really know what was going on that day. This could potentially lead to depriving the patient of services. You know, as you're reviewing the chart and you're trying to make decisions on what's best for the patient in the next visit and the future visits, depending on what's noted in the chart, you could deprive that patient of services. In addition, if you're charging that patient a copay or some additional cost, could be placed on the patient. As I think of some of the cases that I've worked with over the years, I wanted to go back to depriving the patient of services. We oftentimes, as we're reviewing charts and trying to decide the best interest of the patient and how to take the care plan, the service plan to the next level, we look at what they've done in the past. And if we're reviewing a worker's notes and you know, she got that visit or this was going on, I don't see why we would continue doing that. It looks like she's doing well, and potentially the patient's not doing well, and we don't have a true reflection of what's going on there, and so decisions could be made based off of bad information. In addition, here's some common fraudulent practices. Billing for services that were not provided. That's what happened in this case. Intentionally misrepresenting the nature of the service performed. Intentionally misrepresenting the date of service was provided. Maybe you're putting the date down for tomorrow or yesterday because of some sort of deadline, and so you've changed the date of service to benefit you or benefit your program. Intentionally misrepresenting the condition or maybe the diagnosis made. Maybe you're diagnosing a patient with a higher coded diagnosis to help with billing or to help with whatever it is that you're trying to adjust. Also, intentionally misrepresenting the charges for services performed. Oftentimes, you know, it looks like somebody is charged for maybe a service that they didn't actually perform or charging for a higher service. Intentionally misrepresenting the provider or the recipient of the service. So maybe you provided the service, but you didn't provide it to the person who had the insurance. I mean, you provided, to the person who didn't have the insurance. And so you provide it to somebody else so that you can get paid. And then performance of unnecessary services for the purpose of financial gain. And some of this information came from the National Healthcare Anti-Fraud Association. So pull some of that information. Unfortunately, I think we've probably come across some of this over the years where people have misled in their documentation and put some. We definitely read about it in the news where some different offices have gotten in trouble and find themselves in court over fraudulent billing. So that brings us to our next skit, privacy and confidentiality, something that we really, in the healthcare profession, push with HIPAA and other laws protecting the patient's privacy and confidentiality. So if we can go to the skit.
First of all, thanks so much for coming in. It's been really hectic at the office.
Well, thank you for seeing me.
Of course. Before we started, I went ahead and pulled your chart because I wanted to see where we left off from our last visit. So, how you been doing?
I'm having a few issues at work.
Issues like what?
Well, I'm late to work a lot. I don't realize how late I'm coming in, and I forget to call my boss.
How is she reacting?
She gets mad. They expect me to be there. I don't call and let them know where I'm at, so she gets upset.
Excuse me, I'm sorry to bother you, but we have an issue at the front. Can you come now, Miss Harris?
Remember, I was telling you it's been really hectic. I'll be right back.
So, our actors actually had a little fun with that skit. They, as you can see, the practitioner had to get up and leave the room, and she had left his file there in the seat. And though, he does have the right to some of his information, there are some rules related to that. But then he decided to go ahead and look and see what else he could find, and he found 3 or 4 other files on other patients and decided to, do a little snooping and find out what else he could read there. Unfortunately, privacy and confidentiality happens. We have breaches of that on occasion, and there are ways to take care of that. But the biggest piece is not putting yourself in a position where that could happen. When I went to the Code of Ethics for social workers, there was an entire section of privacy and confidentiality that's outlined there. And so I just took a few of them. As you can see, it goes from A all the way down to way on down the alphabet. And but I picked out a few that kind of related to this situation. But please go back and review the entire privacy and confidentiality section when you have a chance. The first one I want to talk to you about is there in A, and I think that part has been with the Code of Ethics since the inception of the code back in the early 1960s, that social workers should respect clients' right to privacy, and we shouldn't solicit private information from or about clients except for professional reasons. And once private information is shared, then there's a standard of confidentiality that applies there. Down in F, it talks about social workers providing counseling service with couples and groups, families, that they need to have an agreement amongst everybody there about the confidentiality, considerations on whether confidential information is going to be exchanged. In G, it goes on to talk about clients involved in groups and how the information is going to be shared as well, and disclosures. It talks about policies concerning the social worker's disclosure of confidentiality among those parties involved. H talks about social workers should not disclose confidential information to third-party payers unless the client has authorized such disclosure. In I, it talks about electronic confidential information electronically in person. Social workers should not discuss confidential information in public or semi-public areas such as hallways, waiting rooms, elevators, and restaurants. And I put that one in there specifically because, unfortunately, sometimes we find ourselves in the hallway talking to a colleague, and the information might come up. We think we're in a private setting, even though we're not in a private setting, even in the bathroom or maybe even in a public in the elevator. And so the code specifically talks about these areas, and just want to remind you that those are not places to discuss confidential information. J talks about protecting confidentiality of clients during legal proceedings. When a court of law or other legal authorized body orders social workers to disclose confidential information without the client's consent, there's some additional information there related to that. K talks about protecting the confidentiality of clients when responding to requests from the media. And then the last L there talks about protecting the confidentiality of clients' written and electronic records and sensitive information, reasonable steps to make sure the client's records are stored at a secure location and that the records are not available to others who are not authorized to have access. And that one kind of goes to our skit where the worker was busy, she was distracted, a lot going on in the office. She had already pulled 3 or 4 different files, probably had a long list of patients that were waiting to see her, and so she thought that the information's in her office, it's there safe, and didn't think about the possibility of being distracted and being pulled out of the office, and then somebody who was not authorized having access to that information. So I wanted to point out a handful of different things here that relate to public health. The Health Insurance Portability and Accountability Act of 1996, aka HIPAA, as we all know, came about back in 1996, and it certainly has been added to over the years. Public health has specific policies. Our HIPAA privacy and security policy has just recently been updated in 2018. Is 2018-001. Our compliance and ethics policy is 2015-004, and our employee handbook for semi-monthly employees also talks about privacy and confidentiality. So as you have time, please review those policies. Wanted to talk about some specific disclosures. Talked with our compliance office and asked them what are some of the issues that we have here at Public Health. And they gave me a list, and so the first one is mailing patient information to the wrong patient, and unfortunately that happens sometimes in our county offices. We're either in a hurry, we pull the wrong patient's name. Certainly can understand how that might happen, but paying attention to what you're sending out and who you're sending it out to, and making sure that you have the right patient is extremely important. Also, mailing PHI to the wrong provider, making sure that you're sending it to the right group that you're trying to send it to. I don't know that we fax information like we used to, but that was always a concern back in the early part of the 2000s, was making sure that there was somebody on the other side of that fax machine to get that information. A lot of times now we're either sending it through the hand mail or sending it through the regular mail, or maybe even sending it through electronic means, whether we're sending it through email or some other means, but making sure that that information is going to the right patient or to the right provider. Additionally, with the new electronic health record, apparently there's a label that might have PHI information on it that's sometimes being used accidentally or inappropriately in mailing out information. So we want to make sure that when we're printing labels, that we're printing the correct label, one that doesn't have maybe a social security number or a date of birth or something like that that's on the mailing label when we're sending that information out. Replying to it all in an email and including PHI. So you get an email and you're like, well, let me send a reply, and you notice that there's or you don't notice that there's 8 or 9 people listed in the email, and that PHI is going to all of those folks, and maybe they don't have a need to know all that information. And so that's another common disclosure. Discussing PHI with someone that's not included in the consent release form. And so that's one maybe that we deal with from a nursing or social work standpoint. We're very eager to find our patients. You're trying to get maybe a child back in to the office to get a lab drawn or to be seen for some other means, and you've tried 15 different phone numbers and you've called everybody you can, and you finally get somebody, and but they're not on the consent release form. And it's okay if you tell them, hey, can you get the word, please call us, but it kind of, if you start spreading information that's doesn't need to be released, then that's where we've stepped across the line and we've had a disclosure. Discussing patient information outside of the healthcare setting, kind of talked about that a few minutes ago in the code, where we're talking about information in maybe in a meeting about a patient that we don't have a need to know for everybody that's in that meeting. Maybe it's in the elevator, maybe it's in the bathroom, maybe it's in the hallway. And then the last one is employees illegally accessing patient files. And so I know I've heard of hospitals where maybe a nurse was looking up patients' information and then decided, hey, I wonder if a friend of mine's here in the hospital, and they click over and they look up their information. Or maybe some of our skits we've had in the past where did I see so-and-so in the health department? I wonder what they were in here for. And so now we're pulling up that information and accessing patients' files to, I guess, just to be nosy or to try to learn something we don't have a right to know. And so I want to just bring those to your attention and encourage you not to do those things. Also, there's some other potential situations for disclosure. Leaving PHI or documentation on your desk that's not secure, or maybe in your office space. Again, that's sort of what happened in our skit. She left those files over on the bookcase as she stepped out, and there was a disclosure there. In addition, we've had some situations where PHI was put in a recycle can or a box that's not secure. And so, we have secure trash bins that are locked that you can put that PHI information in, but putting the information in a box or in one of your blue cans underneath your desk or in your office that could be disclosed accidentally, or somebody snooping through or looking through it is inappropriate. Another issue, lost or stolen devices. So you've got a laptop maybe, or a jump drive that has patient information on it, and it gets misplaced, it gets stolen, and now that PHI is out there available for whomever. And then the last is the potential for texting patient information if you don't have the patient's correct number, or you don't know who's going to get that information. Maybe somebody else has their phone or can see their phone, and so that information is being texted. And so just some things to be mindful of as you are sharing information and trying to get your patients in, talk to your clients, making sure that you protect that patient's information. Also, so a couple other things that lead to it are lack of training of HIPAA regulations, and so that's why we have the HIPAA trainings. That's why we talk about HIPAA regularly. We talk about protecting patient information, and so making sure that everybody in your office has had the training and that they understand how important it is to protect patients' information. And then, of course, social media. We're going to talk about that a little bit more in a few minutes, but I was excited. I was down in a county in South Alabama a couple of weeks ago, and I saw signs all over the clinic that said, do not take pictures or do not take video of patients or anybody for that matter, because we wanted to protect the patient's information or patients being in our clinic. And so being mindful of that, not taking pictures, not sharing anything on social media that might disclose information related to your patients or your clients is extremely important. So that brings us to our next skit. This was on dual relationships, and this one was kind of hard to explain to those that aren't in the world of social work or healthcare, how having a dual relationship is, an ethical dilemma or an ethical issue. So if we can go to the clip.
Well, hey, Mr. Brown, Tommy, this is a surprise.
Miss Betty, it is a surprise. We didn't know you lived in this neighborhood.
Sure do. Hey, Tommy, how have things been going since our last session?
It's all right. I did really good on my last 2 tests.
That's awesome. I know you were really worried.
Yes, ma'am.
You know, he has a long way to go, but we appreciate your help.
Well, we'll work together on that. Well, what brings you to my neighborhood?
Well, actually, I just started a lawn care business. Here's my business card.
Thank you.
We can cut grass, fertilize, design flower beds, plant flowers, anything a customer may need outside. We even pressure wash.
And that's my favorite part. I love pressure washing.
Do you really?
Yes, ma'am.
Well, I know you can see a lot of progress with that, getting rid of mildew and all that stuff, and I bet it keeps you busy.
Yes, ma'am.
Goodness gracious. Well, I know you can tell by my house that my lawn guy quit. I mean, the grass is up to my knees, and my house, it needs pressure washing, something awful. So you came at the right time. You really did.
Well, we really have some affordable prices.
Oh, I'm sure you do, and I'm sure you could give me a great price. I mean, after all, I would have you do both, and I did help you with Tommy.
Well, like I said, we have affordable prices.
Do you have a pen?
I do.
I'm going to give you my personal cell phone number, and if you will call me and give me a price, and I know it will be a great price.
Okay.
And I know you can fit me in on Friday,
Well,
right?
Like I said, we're just getting started, and we already have another customer on Friday.
Well, but I know you can fit me in on Friday. So I'll see y'all Friday.
So our clinician there in her own house just walks off and leaves them in the den. But anyway, you can tell through the skit here that we showed that there was already a previous relationship, that the clinician had been working with Tommy, and that they were continuing that counseling, that this was not a relationship that was over, but it was a relationship that was continuing. They just happened by her house. They didn't know that that's where she lived, and they were there on their own lawn business. However, that from there, it kind of took off. We kind of expanded on this specific situation to show that there was going to be a dual relationship that was going to occur there. In addition, she also gave him her personal cell phone, and so that the lines there were getting blurred even more and more as the skit went along. I want to talk about the Code of Ethics. Section 1.06, Conflicts of Interest, talks about how a social worker should not engage in dual or multiple relationships with clients or former clients in which there is a risk for exploitation or potential harm to the client. Goes on in the second part to talk about dual or multiple relationships occur when a social worker relates to a client in more than one relationship, whether professional, social, or business, and dual or multiple relationships can occur simultaneously or consecutively. And so having that dual relationship is not an ethical issue in itself. It is the potential for the social worker to, or the relationship to affect the relationship, the professional relationship with the client. And that's the real issue here. I want to talk about why there's those dangers, and so I listed some of the dangers there. There's potential for exploitation to the patient, and so we saw that with this clinician. She was trying to get a better deal, and they were just starting out their business, and she didn't really care that it might potentially hurt their business. We already had a commitment on Friday, but she was expecting him to be there on Friday to take care of her yard and potentially have some harm to the business. And certainly the relationship, the business, is the dad's there, but we also connected the dots with the client, the patient, is a part of the business. And so he does the pressure washing and probably helps with some of the other parts of the business as well. Potential for harm or damage to the patient. So, the patient potentially is going to lose trust with his worker, lose trust with the process that he's going through, and so there could be harm there. In addition, could disrupt the therapeutic relationship. Again, that trust bond is broken. We didn't talk about this in this specific skit, but we know that there are other instances where dual relationships get involved. Specifically, maybe a relationship where it's not only it's not a business relationship, but maybe it's a social relationship. That social relationship then becomes more of a romantic relationship, or potentially even a sexual relationship. And all of those are extremely dangerous and unethical. The final danger that I listed here is it protects the healthcare professional from liability. And so, if you don't have the dual relationship, when you have that dual relationship, there's the potential for the patient to come back and say things that maybe really did not happen, or to read into the second relationship more than was really there. And so by drawing the line and making sure that you keep a single relationship, it protects the healthcare professional. So it's not always possible, especially in small towns, to not have dual relationships. So here's some questions to ask when those relationships are unavoidable. First is, who does the relationship benefit? Is it benefiting the patient, or is it benefiting the clinician? Second, have the risks been discussed with the patient and client? So there's that risk there, and does the patient or client understand what those risks are? And finally, has the patient provided informed consent? So you've talked about the risk, you've talked about the potential there, and the patient has now understands that risk and has provided consent. So it brings us to our next skit. This one's on alcohol use and abuse, and so if we'll go ahead and roll the skit here.
Hey, man, what's going on?
Hey,
Enjoy a long weekend?
I sure did. How about you?
Yeah, it's all right. What you doing tonight?
I don't have any plans.
All right, Taco Tuesday, because I need a big margarita.
Hey, that sounds great. That sounds great.
5 at the
5
restaurant?
o'clock. 5 o'clock. 5 o'clock. Who needs to wait till 5 o'clock? Take this, HR director.
So, by the way, that was our HR director who was kicking back with a drink at 9:35 in the morning, if you notice the clock in the background. You know, again, alcoholism is not something to laugh at, but we tried to make this a little humorous. And so I want to talk a little bit about alcohol use and abuse. Unfortunately, when I looked at the website and I've done some research, alcohol use and abuse continues to be a huge problem when it comes to the healthcare profession. Healthcare profession is extremely stressful, and unfortunately, the stress sometimes gets to our healthcare providers. And so I pulled some information. This is from the code, from section 4.05, talks about impairment. Social workers should not allow their own personal problems, psychosocial distress, legal problems, substance abuse, or mental health difficulties to interfere with their professional judgment and performance, or to jeopardize the best interest of the people with whom they have professional responsibility. He goes on to talk about that they should take immediate consultation and take appropriate remedial action by seeking professional help, making adjustments in their workload, terminating practice, or taking any other steps necessary to protect the client and or others. And also in the nurses, it talks about the denial or suspension or revocation of a license, and the board may deny a license or revoke a license upon proof that, under D, it talks about incompetent due to the use of alcohol or addicted to the use of habit-forming drugs to such an extent as to render him or her unsafe. And that's from the Alabama Nursing Practicing Act. So, I pulled a few statistics. Like I said, nurses and other helping professions show higher rates of alcohol addiction than other professions. 83% of healthcare professionals consumed alcohol at least once in the last year, and 16% engaged in binge drinking. So, we do know that alcohol abuse and use can be very detrimental into the relationship that is formed between the patient and the clinician. It continues to be something that just needed to bring out. And one of the reasons that folks are disciplined, both within nursing and within social work. And so, with that said, we're going to move on to the next skit. This one's on competency and continuing education. This one may hit home a little bit, so we'll see. If we'll go ahead and roll the skit.
Hey girl, what you doing?
Hey Meg, I'm watching this training on ethics and trying to get some filing done. Not much.
Well, is the training any good? I mean, you don't even have the sound on.
I have no idea. I mean, I'm trying to get this filing done, trying to watch this training. I've got a patient coming in later, and if my manager says one more thing about billable time, it's going to be me and her. I'm serious. I'm tired of it. Sick of it. How do they expect us to get all this stuff done?
Beats me.
It's ridiculous.
I mean, I don't have a clue, but hey, you want to go get something out of the snack machine?
Yeah, I need a break.
And wait a minute, on second thought, you know how you and I are about coffee?
Yes.
I think somebody made some fresh coffee in the break room, and I think somebody even brought donuts today.
Let's go. I wonder if they got sprinkles, because I can always get this done later.
I hope so. Oh my goodness, I hope so.
So our actresses definitely had a lot of fun with that one, and even ad-libbed a little bit. So, you know, continuing education is extremely important. There's a reason we do these trainings. Is to make sure that we're staying abreast of the most recent information, to remind us of things that we already know, and to learn from others in the profession. We talked earlier about one of the 4 ethics in healthcare, and one of them specifically spoke to the need to stay competent, and that way we're able to help our patients. added a little bit here from the Code of Ethics. It talks about social workers should provide services and represent themselves as competent only within the boundaries of their education, training, license, certification, consultation received, and supervised experience and other professional experiences. In addition, social workers should provide services that are in techniques that they are approaches to new only. I've messed that all up. But anyway, continuing education is extremely important. I wanted to add from the State Board of Examiners, social work examiners, the requirements for continuing education. And as we know, each of the levels of social worker are required to have 30 contact hours of continuing education, whether you're at the bachelor's, the master's level, or even at the independent living. In addition, 3 hours of ethics and 3 hours of contact hours are required in clinical to renew your license. And in addition, there's 10 hours of classroom hours that are required and out of the 30. As far as nurses go, in addition, the social workers also to have mandatory child abuse and neglect reporting training. The nurses required, back in 1991, it was put into they were required to have continuing education, and their state that they have to have 24 contact hours of continuing education credit, as well as paying their fees. And so continuing education is required. I would say that in the skit, she didn't really watch the training. She just kind of had it on. And in addition, when she went to the break room, she left it playing and wasn't really paying attention. So the information wasn't being absorbed, certainly wasn't being reviewed. I know that there's a lot going on. We are all very busy, but the requirements there, and it certainly is from an ethical standpoint, you have a responsibility to your patients and your clients to be up to date on the latest information. In addition, a lot of discipline occurs with both social workers and nursing because they haven't completed the required continuing education credits. And so that's something that we see regularly is someone who's come up a little bit short in their hours. Maybe they don't have the clinical hours or they don't have the ethical hours that are needed. And so we wanted to take an opportunity in this training just to review that. With that said, let's move on to our next skit. We've talked about alcohol abuse, opiate abuse, and prescription medication continues to be a huge issue, and so it's something that also discipline occurs with, and so we wanted to highlight this in this skit. If you'll go ahead and roll the skit.
Miss Bailey, I'm Tina, your home health social worker. We met last week, and I'm the one who called you yesterday about coming by to visit with you today.
Yes, I remember.
Good.
Come on in.
Oh, thank you.
Come on in and have a seat at the table.
Okay, thank you.
I've been watching my story, but I'll turn it off
Okay.
so we can talk.
All right, thank you for doing that.
Would you like something to drink?
Oh, no, I'm only going to be here for just a minute.
Okay.
If you remember, the reason for my visit today is that the doctor wanted me to go over your medications with you and make a list for him to show him exactly what you're taking. So is that okay with you?
That's fine. I have them all right here.
Oh, perfect. Perfect. All right, well, let's get started.
Okay, let's see. This one I take for my pressure.
Okay. All right. And how often do you take this?
I take one pill one time a day.
Okay. All right. And
he's had to change it all around, though.
Oh.
I've been on a bunch of different pills.
Okay. Well, how is this one working for you?
I think it's working good.
Okay. Good. 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 All right. And what about the next one?
Let's see. This one right here, it's for my arthritis. I have some pain in my joints.
Okay.
And it does seem to help.
Oh, well, that's good. So how often do you take this?
I take just one pill a day, but then if it's really acting up, I can take another one.
Oh, okay. All right. And next?
Let me see. This is my calcium.
Okay. And how often do you take this?
I take one twice a day.
All right. Next.
This is just for my heartburn.
Oh, okay.
You know, we all have heartburn from time to time, and so that's what that's for.
Okay. And how often do you take this?
I don't take that every day. It's just when it acts up.
Okay. All right. Well, let's put it on here, though, since you are taking it. All right. What's next?
Let's see. I believe this is Claritin, and it's for my allergies, you know. Living down here in the South, we all have our allergies, don't we?
Oh, yeah. All right, so how often do you take this?
I just take one once a day, but he said I could take two.
Oh, okay. All right, but you're just
Two
taking
twice
one?
a day.
Okay. All right, what's next?
Let's see. Let me see. This one, I don't really take it.
Okay. All right, well, let's just leave it.
Okay.
Let's not, don't put that one on the list.
Now this is just Tylenol.
Okay, do you take that?
Sometimes if I have a headache.
Okay. Well,
If I don't have a headache, I don't take it.
Okay, well, let's put it on the list, though, since you're actually
Okay.
taking it. All right, next.
Let's see. This right here, this is some kind of cough syrup.
Okay, are you taking it?
No, I don't really take it.
Okay, all right, well, let's don't put it on the list
He
then.
gave it to me, you know, when my allergies act up if I have a little cough.
Okay,
But I don't really take it.
okay, all right.
Now, I don't take it today.
Okay, all right, so
Let's see.
what else?
This, I'm not sure really what this is.
All right, well, let me take a look at it a second. All right, Miss Bailey, do you have a dog?
I sure do. Her name is Fluffy.
Oh.
Because she's so fluffy.
Well, that explains this.
She's my pride and joy.
This is Fluffy's flea medicine.
Oh, my goodness. I wondered where I put that. Thank you so much.
Oh, you
for
are quite
finding it.
welcome. You might want to keep that somewhere else other than with
Okay.
your medications.
I'll put it somewhere else.
All right. Is there anything else?
Let me think. Yes, I do have one more.
Okay.
And it's over here. Let's see. The doctor gave me this last year when I fell
Okay.
for pain. But I never did take it.
Oxycodone. And you're not taking this now?
No, I never did take it, and I don't need it.
Okay, well, I'm not going to put it on your list here, but you know, since you don't need this anymore, would you like for me to take it and dispose of it for you?
Oh, yes, that would be so
You know,
nice.
it's really not good to keep this kind of medication around your house.
That would be so nice of you,
All right, well, I'll be more than happy to do that for you.
because I didn't know what to do with it since I wasn't taking it.
Okay, so is there anything else that I can do for you today?
Let me
Is
think.
that all of your medicines and...
Let me think. I did get a letter from Social Security, and I just don't understand it. Would you help me with that?
I'll be glad to take a look at it for you.
I'll go get it. It's in my bedroom.
Okay, I'll just double check my list here while you're gone.
Okay. I'll be back in just a jiffy.
Okay, all right. I'll be right here. Oh my. This is really gonna come in handy.
Again, our actresses had a lot of fun with that one, and unfortunately, that's something that happens on occasion. We go into a home, and there's a lot of medications that need to be reviewed. It was interesting that she had a couple of medications that she didn't take, but it was only the one, the opiate, that she was interested in disposing of for her. And over my career, I probably early on in my career was one of the first times that I saw this. There was a nurse at a local hospital that I worked at who had been taking medications, and found out later she was taking them and using them herself. And so, and again later on, I was in a child care facility, and we had a healthcare worker that was taking the children's ADHD medicines and putting it, and we'd get to the end of the month and wonder why we were short a couple of pills, and we finally were able to figure out what was happening. And so it happens in more regularly than we probably wanted to admit. The information that I provided on the slides is the exact same stuff that relates to the alcohol. I just wanted to highlight it because alcohol and opiates or prescription medications are two of the reasons that discipline occurs with both nurses and social workers and even physicians. So I pulled some statistics. Healthcare professionals have easier access to addicting substances. We saw that here in this skit. Healthcare profession is very stressful. We talked about that earlier. 1 to 2% of healthcare professionals each year develop some form of addiction, and 10 to 15% of healthcare professionals will misuse substances in their lifetime. In addition, it affects all the professions of the healthcare fields, not just one or another. Prescription drug abuse is 5 times higher among physicians than the general population, and nearly 7% of nurses who use prescription drugs for non-medical purposes, and this rate's higher than the national average. Healthcare professionals have a legal and ethical responsibility to protect their patient and clients from drug abusers, and that comes in a lot of different, in multiple roles. It could be that it's a caregiver that is addicted to the drugs. It could be a coworker that is seeing patients and that you are aware that there's some addiction that's going on there. Or it could be, maybe the parent of a child who's got some addiction. And so healthcare professionals have a legal and ethical responsibility to protect them. In addition, we read a little bit about that, ethical responsibility to seek professional help if you need it, if it's something that you're struggling with. And finally, healthcare professionals should report to their employer, state boards, agencies, regulatory bodies, and professional organizations when impairment interferes with practice. And so it's extremely important that we protect our patients, and that goes even as far as reporting folks, unfortunately. So our last skit is on social media. I added this one because I wanted to highlight some of the changes to the NASW Code of Ethics. So if we'll go ahead and roll this skit.
Okay, so we just got our card, right? And we're kind of getting geared up and getting excited.
Oh my goodness, girl, what is that? You got a train in your pocket?
No, that lets me know when Miss Davis has posted some information on social media.
Oh.
So I can get some dirt on her.
So you're stalking now?
Stalking? No, that's not what I do. I'm a researcher. I'm just getting research, particularly some dirt on her, just to see what's been going on. So let's just see what's been up. Let's see what's going on. Looks like her daughter's over there posting some pictures about a birthday party. Let me scroll down.
Those are cute kids. Grandbabies?
Looks like her grandson. They had a party. And would you look at the size of that cake? That is absolutely ridiculous. She has type 2 diabetes. Do you think somebody with diabetes is supposed to be eating a size of cake that big?
It looks good.
It's not good. I've been working with her for 3 weeks, 3 whole weeks. She promised me that she was going to stop, and she's not stopping. Just wait till I see her next week. It's going to be on and popping. You understand me?
Oh, she's going to regret those French fries, too.
Yeah, she's going to regret a lot.
Yes, they definitely had fun with that skit. Again, I wanted to highlight some of the changes that have occurred with the Code of Ethics with social workers. This one, we actually had some discussion after we had shot this. Folks, discussion, can't you Google your patients? It's hard to find our patients. Sometimes, monitoring and keeping up with them. And so let's see what the code says. Some things that were added back to the informed consent piece in section 1.03 talks about social workers should discuss with the client policies concerning the use of technology and the professional service. When they use technology, in Section F there, it should get informed consent from the individual using these services during the interview process. on down, it talks about social workers should obtain client consent before conducting an electronic search on the client. Exceptions may arise when there's a search for purposes of protecting the client or other people from serious, foreseeable, or imminent harm. And then 1.07, back to privacy and confidentiality. The social worker should respect the client's right to privacy, and we talked about that earlier. Is not soliciting information. And in this specific case, she was out there trying to get dirt, as she specifically said, and snooping on her patient, and probably had not consented to those types of searches. And once this information is found, standards of confidentiality apply. So, again, I wanted to highlight the changes. Back in August of 2017, the NASW Delegate Assembly approved the revision of the NASW Code of Ethics. Many of these revisions relate to communication technology, and that includes social media, text messaging, telecommunication equipment, confidentiality, record keeping, and disclosure of client information. So with all that said, these are references to the training. I wanted to just make you aware that there have been changes to the Code of Ethics as it relates to telecommunications, and encourage you to go and review those changes, to understand it, to respect the confidentiality of your patients, as well as, protecting your own practice as it relates to electronic and protecting patient information. So, with that said, are there any messages, any emails? I certainly thank you for being here with us today. It was fun doing this training, the skits. I again want to thank my actresses. They were great sports and had a lot of fun with that, but certainly a lot of work went into it, and I want to thank them for that. With that said, no calls or no emails. Okay. Well, we'll wrap up the training, and again, thank you for being here with us.